Peace. Welcome, welcome to the YouTube live book reading of Clinical Application of Respiratory Care. I'm your moderator and narrator, Uriel. Thank you so much for being here and reading books with us. Peace, YouTube. Clinical Application of Respiratory Care. I'm your moderator and narrator, Uriel. So, peace, YouTube. We begin Section 3, Bronchial Hygiene Therapy. Chapter 8, page 155. Retained Secretions. Welcome. Thank you for all being here and reading books with us. The peaceful place on YouTube where we read books and learn from masters. I'm a master fitness trainer, Ronald. Thank you so much for reading with us in this peaceful place. All right, here we go. Chapter 8, Retained Secretions. Pulmonary physiology is traditionally taught almost exclusively in terms of pulmonary gas exchange. There can be no challenge to the statement that the prime function of the pulmonary system is to allow atmospheric gases to exchange with blood. A clean tracheal bronchial tree must be maintained to adequately accomplish this function. Since atmospheric air is constantly moving in and out of the tracheal bronchial tree, there must be mechanisms for keeping the conducting tubes free of foreign particles. In addition, there must be mechanisms for preparing the inspired gas for contact with the lung parenchyma. For preparing the inspired gas for contact with the lung parenchyma, the air must be warmed, humidified, and cleansed. Prior to 1955, there was little concern for the non-respiratory functions of the pulmonary system. Over the past 20 years, there have been numerous investigative studies on this subject. However, clinical medicine has been slow to appreciate the importance of these non-respiratory functions in health and disease. This slow acceptance stems in part from the fact that the pulmonary system is mechanical, and therefore many of the therapeutic modalities applicable to its care and maintenance are mechanical rather than pharmacologic. Internal medicine has paid great attention to the bronchial spastic elements of pulmonary disease, primarily because bronchospasms is readily reversible pharmacologically. Retained secretions occur with far greater frequency than bronchospasms in the critically ill, but there has been great hesitancy to accept the techniques and modalities for bronchial hygiene. Peace, peace, highest heart love. Thank you for reading with us. The progress of clinical respiratory care over the last decade has erased any legitimacy to the question. Is bronchial hygiene necessary? Today, the question is, how should bronchial hygiene be applied, and how do we evaluate its effectiveness? Before addressing ourselves to the particular techniques and modalities of bronchial hygiene therapy, it is essential to discuss the normal bronchial hygiene mechanisms. Only if we understand these processes and what occurs if they fail to function adequately can we begin to understand the rationale for the application of respiratory therapy modalities of bronchial hygiene. Peace, peace. Page 156 at the top. We are in chapter 8. We moved up to chapter 8. All right. Bronchial hygiene therapy. Thank you for being here. Highest heart love. The top of page 156, the mucociliary escalator. The scanning electron microscope has been applied ingeniously to document the existence and function of the microciliary escalator. In the large airways, this is a continuous blanket of mucus covering the tracheobronchial tree epithelium that is mobilized by the forward motion of cilia. Yes. Figure 1.5. The ciliary action causes the mucus blanket to be mobilized in a continuous motion towards the hilus of the lung, moving eventually to the larynx, where the mucus is moved into the pharynx and swallowed. How the mucus flows through the larynx and into the pharynx is unknown at the present time. Since the larynx does not have cilia, it is a mystery how this flow continues to the pharynx. The process of moving mucus has been referred to as mucokinesis. The mucus blanket moves at a reasonably rapid rate, 1 to 2 centimeters per minute, and can completely cleanse the normal adult lung in less than 20 minutes. This normal bronchial hygiene mechanism depends primarily on two factors. One, appropriate ciliary activity, and two, appropriate mucus production. Thank you so much for the likes and subs. Highest heart love. Peace. Divine rising. Peace, peace, family. Thank you so much for reading books with us. We are live on YouTube, pushing towards 500 reading books here on YouTube. So highest heart love and honor. We're at the in the middle of page 156, ciliary activity. Ciliary activity appears to be affected by numerous pulmonary and non-pulmonary stresses. Numerous direct pulmonary insults, which such as smoking, tracheal foreign bodies, positive pressure ventilation, high inspired oxygen concentrations, tracheobronchial disease processes, and many others affect the action of the ciliary processes. For our purposes, normal ciliary action can be assumed only in the presence of a healthy and undiseased state. Any physiologic stress may result in abnormal ciliary function. Mucus production, down at the bottom of page 156. For those reading along, also in the replays, so you'll see in the playlist, you can just tap on any of the books on this channel on the playlist, and it'll read the entire book with you. Thank you so much for all the book lovers community. High's heart love. Mucus production. Mucus production is a complex and poorly understood process at the present time, We know that the prime sources of mucus are the goblet cells of the pulmonary epithelium and the mucus glands of the submucosal area. The mucus is constantly being produced and extruded onto the surface of the pulmonary epithelium. The mucus must have a very specific hydration, pH, electrolyte balance, and other numerous other factors for proper mucokinesis to occur. Mucus rheology, the study of flow characteristics, is a very complex subject with many highly controversial factors. In general, the mucus has viscous and elastic properties that allow a continuous motion to result from the intermittent forward pulling of the cilia. Ding! That's huge, right? It's just constantly flowing. Rheology, the study of flow characteristics. This is very powerful. Peace, you too. Hi, it's Heart Love. Thank you for reading with us. Being here. Much appreciation. The outer mucus layer, gel layer, is extremely viscous and normally flows continuously toward the larynx. See figure 1.5. Any mucus abnormality can cause the mucus blanket to slow or stop. Obviously, any discontinuity in the mucus blanket is the large airways would cause poor forward motion and result in retained secretions. There are a multiplicity of factors that can cause abnormalities in mucus production. Any pulmonary epithelial inflammation, any abnormality of the mucus and serous glands, or in fact, almost any disease process that involves the tracheobronchial tree. In summary, normal bronchial hygiene is dependent upon normal mucus production and ciliary function. Any disease process, but especially one involving the pulmonary system, may result in abnormal mucokinesis, which will lead to retained secretions. Although investigations into the details of mucus production and ciliary motion continue, there is more than enough evidence to substantiate these generalizations. Parenchyma hygiene, middle of page 157. The alveolar fluid lining. Thank you for the likes and subs. Highest heart love. The mucus blanket is not found beyond the terminal bronchioles. There are no mucus secreting glands nor cilia in alveolar epithelium. However, alveolar epithelium is lined with a fluid, and it is believed that this fluid is mobilized into the bronchiolar mucus blanket. Although this is a controversial subject, it seems reasonable to assume that the alveolar fluid lining is constantly mobilized in some manner to become part of the mucus blanket. Thank you so much for reading here. Never give up on my man. Thank you so much. That's right. We never give up. That's right. We have to. This is our part of way as the light workers of showing others they can do it, right? Leading the way. That's what us light workers do. That's why we continue to heal people no matter what, because that's our purpose. And so, reading on this channel, the books, that's my purpose on this channel and on this YouTube feed is to be and provide peace wisdom, and mastery to the people. Thank you so much for being here. Much love. Microphages. An important defense mechanism of the lung parenchyma is alveolar macrophages, figures 1-4. These are large cells that are mobile and ingest foreign material, phagocytes. Their origin is believed to be in the bone marrow. These macrophages play an important role in pulmonary disease. Their role in normal parenchymal hygiene is controversial. The sigh. The normal breathing pattern involves varying tidal volumes in conjunction with intermittent deep breaths, sighs, 6 to 10 times an hour. This variability of inspiratory volumes plays a great role in preventing alveoli from collapsing, the miliary or patchy atelectasis. Many believe this is a normal bronchial hygiene function. The cough mechanism. This is major. Oh, I'm going to thank you so much for reading with us. Highest heart love. All the love. I see the hearts. Oh my goodness. Much love. Thank you. Thank you for the likes and subs. We're pushing to 500 subs on this channel where we read books. So thank you so much for helping me get there. Much honor. This is very key. All right. The cough mechanism. I love anatomy and physiology. I just love it. When malfunction of the mucociliary escalator occurs, a very basic defense mechanism comes into play, the cough. A pulmonary defense mechanism which attempts to maintain adequate bronchial hygiene in spite of inadequate normal mechanisms. There is no evidence that the cough is necessary in normal pulmonary hygiene. Rather, it functions in the presence of abnormalities such as copious, dry, or thick mucus, poor ciliary activity, and diseased pulmonary epithelium. The cough is the major defense against retained secretions and is often obtunded or destroyed in pulmonary disease. Much of respiratory therapy is involved with the maintenance of bronchial hygiene, and therefore it is aimed at augmenting or replacing the function of a deficit cough mechanism. It is essential to completely understand the factors involved in the cough mechanism. See, and so with the buildup of a cough, it literally forces that flow, right? It forces the movement of the mucus at a jolted pace. So this is very powerful. Anatomy of the cough mechanism. In the middle of page 158, those reading along and also in the playlist. The anatomy of the cough mechanism. The initiation of the cough mechanism is provided by vagus nerve, the 10th cranial nerve. Ding! Reflexes either from the trachea or the carina. Any foreign body or irritation in the tracheobronchial tree will elicit an afferent vagal impulse to the midbrain, which will result in afferent vagal impulses to the appropriate muscles. Assuming appropriate sensory and motor reflexes, we may consider the cough mechanism as having five separate mechanical components. One, a deep breath. Two, an inspiratory pause. Three, a glottic closure. Four, increased intrathoracic pressure. And five, the glottic opening. Adequate inspiratory volume. One can exhale no more than what has been inhaled. And an effective cough must be preceded by an adequate inspiration. Coughing without adequate inspiration is ineffective, e.g., multiple coughs in a row without intermittent inspirations are called paroxysmal coughing and are non effective coughs. Various investigators have attempted to quantitate the minimum adequate inspiratory volume for an effective cough, and most agree that an inspiratory capacity of at least 75% of normal is necessary. Others have found that a vital capacity below 15 milliliters kg over kg, 6 milliliters over a pound, will result in an inspiratory capacity that is inadequate to provide an effective cough. Regardless of the rules of thumb applied, the principle that an individual must have the mechanical capacity to breathe deeply for an effective cough cannot be ignored. Inspiratory pause. Common sense dictates that if the cough is to be effective, as much as the inspiratory volume as possible must find its way distal to mucus that is to be mobilized. Following deep inspiration, a breath holding maneuver is accomplished for a period of time to allow maximal peripheral distribution of air. In essence, a tracheal to alveolar driving pressure is maintained for as long as possible so that a maximum volume of gas can overcome resistance to flow. The inspiratory pause is a significant part of an effective cough. An individual who is breathing rapidly and shallowly will not hold his breath for any length of time. Thus, he will not provide an adequate inspiratory pause and usually will have a poor or ineffective cough. Glottic closure. We're at the top of page 159. We're all reading along. Highest heart love. Thank you so much for being here and reading books with us. Love to all the book lovers community. Thank you so much, Corey. Peace, peace. Thank you so much. We're in glottic closure. After maximal peripheral distribution of air, the glottis must close tightly. This means that the laryngeal musculature must be intact so that there will be no gas leaving the larynx in spite of greatly increased airway pressures. Adequate glottic function is as important a part of an effective cough mechanism as any other factor. Increase intrathoracic pressure. The basic purpose of the cough mechanism is to provide a high velocity airflow on expiration. This means that the greater the differential between intraalveolar and atmospheric pressure, the greater will be the velocity of flow when expiration begins. With the glottis closed, the prime mechanism for increasing intrathoracic and therefore intra alveolar pressures is to increase intra-abdominal pressure. Increased intra-abdominal pressure will push the diaphragm upward, thereby decreasing the volume of the thoracic cavity. At the same time, the intercostals are brought into play to resist the expansion of the chest wall as the diaphragm is forced up. According to Boyle's law, this must cause an increase in intrathoracic and intra-alveolar pressures since the gas cannot leave the lung. So specific and powerful. A normal cough produces intra-alveolar pressures in excess of 100 centimeters of water, sometimes exceeding 200 centimeters of water. The muscles of greatest importance in the cough mechanism are the anterior abdominal wall muscles from chapter 1. These are the muscles that increase the intra-abdominal pressures and thereby force the diaphragm up to increase intrathoracic pressures against the closed glottis. Much of the bronchial hygiene therapy is involved in the evaluation and augmentation of abdominal musculature function. Glottic opening. After intra-alveolar pressures are increased, the glottis suddenly opens and allows high velocity airflow from the lungs. Peak flow rates may be as high as 300 liters per minute. Purpose of the cough mechanism. Gratitude, all that have come in and reading with us, medical books. So major. Clinical application of respiratory care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. We're at the bottom of page 159, speaking about the anatomy and physiology of a cough. So specific. Purpose of the cough mechanism. A high velocity airflow out of the pulmonary tree will mobilize mucus. Obviously, the more fluid and continuous the mucus blanket, the greater will be the degree of mobilization. It must be appreciated that no matter how effective the cough may be mechanically, it must have an intact mucus blanket to mobilize. In other words, to mobilize retained secretions, an effective cough is essential, but without an intact mucus blanket, the cough will be raspy, painful, and relatively non productive. Thank you for the likes and subs. We're pushing towards 500 subs on this peaceful place on YouTube where we read books and we learn from masters. Thank you so much for reading with us and all to the book lovers community. Uh, Welcome, welcome, YouTube. All right, we're at the top of page 160 in chapter 8, Pathophysiology of Retained Secretions, table 8.1. Retained secretions are so common in diseased patients that etiologic classification is useless. Any insult to the pulmonary system may interrupt normal bronchial hygiene mechanisms and create a potential for retained secretions. Thus, we see the retained secretions are the most common cause of pulmonary malfunction in sick patients. 1. Retained secretions lead to an inflammatory response of the pulmonary mucosa. The hyperemia, capillary congestion, and edema swelling resulting from this inflammatory reaction cause increased resistance to airflow. The narrowing of bronchial lumens caused by partial plugging of retained secretions also causes increased resistance to airflow. This increased resistance to airflow leads to an increased work of breathing. Ding! Increased work of breathing, dealing with the mobilization of the mucosa and the alveolar pressures, right? And the pressures that help to move it along. It's very key. That's why breathing is a pump action because we are pumping oxygen to different areas. And the places that have blockages will basically um, reroute the pressures. Very key. Thank you so much for being here. Just understanding this medical information so we can help heal ourselves and heal others. That's what we do as light workers. Thank you so much. This increased resistance to airflow leads to an increased work of breathing, since it will take more energy to move an adequate amount of air in and out of the lungs. The plugging and inflammation secondary to retained secretions are seldom evenly distributed throughout the lung. Thus, uneven areas of airflow resistance cause uneven distribution of ventilation, which leads to ventilation perfusion mismatch, shunt effect, which leads to hypoxemia, hypoxemia. Even minor degrees of retained secretions may lead to an increased work of the heart and lungs because of the subsequent hypoxemia. Two, greater degrees of retained secretions will cause total plugging of bronchioles and absorption atelectasis of the distal lung parenchyma. Such atelectasis will result in a decreased lung compliance and increased true shunting. The decreased compliance will cause an increased work of breathing. The shunting will cause hypoxemia. Thus, either minor or major degrees of retained secretions may lead to increased work of breathing and hypoxemia. These processes are reversible by mobilizing the retained secretions. See, there's the solution. Peace, peace, Corey and Dana. Thank God, thank you so much. Peace, highest heart love. This is the intelligent part of YouTube, the peaceful part of YouTube, where we understand anatomy and our body and anthropology and physiology. And right now we are reading a medical book. Thank you for being here and reading with us in this peaceful part of YouTube, clinical application of respiratory care. And here is Table 8.1, the potential results of retained secretions. And what you have here is you see 1, the inflammation and partial plugging, 2, the total plugging, and 3, the stasis of pneumonia or fever. So here's the breakdown of it. Thank you so much for reading with us. Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. This is the second edition, 1979. Yearbook Medical Publishers. So there you see the table 8.1. And it shows the increased airflow resistance, increased work of breathing, uneven distribution of ventilation leads to the shunt effect and hypoxemia. And then 2, the total plugging, right, and absorption atelectasis will cause the decreased lung compliance. And then 3, you have the stasis pneumonia or causes a fever. the blockages, right? Non-flow. All right. So it's reversible by mobilizing the retained secretions. Three, when areas of lung become atelectic because of plugging of bronchioles, glandular and cellular activity continue. This leads to stasis of secretions, which is a perfect culture medium for bacteria. Such stasis pneumonia is a common result of retained secretions. In summary, retained secretions are potentially hazardous condition. Any patient with cardiopulmonary disease or a disease limiting the effectiveness of bronchial hygiene may retain secretions if the disease is severe enough. The respiratory care practitioner must maintain a high index of suspicion. It seems reasonable to suspect that any patient with pulmonary diseases who manifests hypoxemia or and increased work of breathing has retained secretions until proved otherwise. And we'll pause right here. Thank you so much for reading Clinical Application of Respiratory Care. We're at the start and beginning, flashing to the middle of Chapter 8, Bronchial Hygiene Therapy. And when we continue back, oh, what? Yeah, keep going. I know it's a tough vocabulary, but that's why I'm reading it. I have the vocabulary to do it. And I care about the people and I understand the anatomy. As a master fitness trainer, it's my duty, as a light worker, it's my duty to take the light, take the torch, climb the mountain. So we're going to continue climbing this mountain. Thank you so much for being here. Let's go. This is how we do. This is why I'm a master. Masters are going to stay mastering. That's just the way it goes. Clinical manifestations. It would boggle the mind to look back over the years and think of how many patients were afflicted with retained secretions that went undetected or were mistaken for some other pathology. With a reasonably high index of suspicion, it is not difficult to spot patients who may have retained secretions. Observation and clinical examination should be aimed at uncovering the symptoms because by the pathophysiology, 1. Increased work of breathing. 2. Hypoxemia. 3. Inadequate cough. And 4. Infection. Increased work of breathing. A patient who has a sudden increase in the work of breathing will complain of dyspnea, the subjective complaint of difficult breathing. Dyspnea is the result of acute change in ventilatory work. It is not observed. It is related by the patient. Objective signs are 1. The use of accessory muscles of ventilation. 2. The tachypnea, rapid respiratory rate. And 3. Preference for sitting positions. In general, the individual who has an increased work of breathing will tolerate positional changes poorly. See that? Uncomfortable breathing, they keep changing their motion. They're not comfortable, as well as increased work of the breathing will make sure that they prefer to be sitting. Why? Because then they're not exerting forces. They're not muscle contracting as much, right? conserving energy. Hypoxemia, page 162. I know, I know. Thank you so much for being here. That's what we do. This is the alpha area. That's right. We are the top, period, on this planet. The top beings. So that's why people enjoy listening to us read, right? Hypoxemia. Hypoxemia, decreased arterial oxygen tensions, will be initially be will initially be suspected by changes in the cardiovascular system. 1. The tachycardia, rapid heart rate. 2. Arrhythmia, irregular heart rate. And 3. Elevated systolic blood pressure. Inadequate cough. A patient who makes frequent, feeble, non productive attempts to cough probably has retained secretions. He may be lethargic, sweaty, and anxious. These patients are often taking cough suppressants to find relief from the annoying, non productive, and sometimes painful coughing episodes. Chest auscultation may reveal bronchi and distant breath sounds. Remember, the auscultation is the listening for the sounds of the chest. Thank you so much. That's what we use and do with the stethoscope when we're going into different places, listening for that cough. Peace to all the nurses, all the doctors, and aspiring MCAT. We're here for you. That's what we're reading this book for. Thank you so much. Common etiologies of retained secretions. Dehydration. Whenever an individual has inadequate body water, the mucus glands have less water available and therefore produce thick and tenacious mucus. Acute pulmonary disease. Whether obstructive or restrictive, an acute pulmonary disease will often lead to retained secretions. The existence of acute pulmonary disease must be accompanied by the clinical anticipation of retained secretions. Tracheal foreign body. The placement of the endotracheal and tracheostomy tubes will cause a decrease in ciliary action and contaminate the trachea with bacteria. Both factors may lead to retained secretions. Generalized muscular weakness. Generalized muscular weakness is most commonly caused by either neuromuscular disease, electrolyte imbalance, or exhaustion. Numerous neuromuscular diseases can cause generalized muscular weakness and an ineffective cough mechanism resulting in retained secretions. Acute illness is often accompanied by electrolyte imbalance. Severe potassium depletion and or chloride depletion can cause muscular weakness. Physiologic stress may lead to a lack of sleep over a prolonged period of time. Patients who experience such exhaustion are impaired in their ability to clear secretions from the airway because we know the lymphatic system is doing a lot of this work while we're resting, right? Without the other muscle contractions. This is very key. Let's hit a pin right there. Bing! Bulbar malfunction. Thank you so much for the likes and subs. We are pushing the 500 reading books here on YouTube. Highest heart love. All right, here we go. Bulbar malfunction. Bulbar malfunction may be caused either by nervous system disease or anatomic malformation. Certain central nervous system and neural diseases, such as multiple sclerosis and polio, can cause selective bulbar malfunction. The recurrent laryngeal nerve may be involved in neck disease or surgery and cause malfunction of the vocal cords. Central nervous system vascular accidents, strokes, can cause malfunction of the glottis. Peace, Marquise. Hi, it's Heart Love. Thank you so much for the beautiful, happy solar return and birthday wishes. Thank you so much. I love you. Sending love and prayers your way. Thank you guys for the likes, subscribes, and shares. We are doing it. This is very key right here. Central nervous system vascular accidents, strokes, can cause malfunction of the glottis. Prolonged intubation of the larynx causes malformation of the vocal cords on a temporary basis, and therefore an inability to oppose the cord's complexity for a period of time. In addition, such vocal cord problems as granuloma, granuloma and other benign or malignant growths can cause malfunctions of the glottis. And abdominal musculature limitation. Abdominal musculature limitations are commonly the result of post abdominal surgery or periodontal periodontis inflammation of the abdominal cavity lining, or paraplegia, paralysis of the lower part of the body. Abdominal surgery involves pain and stress to abdominal musculature that is often a significant limitation to adequate coughing and deep breathing. The pain caused by periodontitis is also responsible for limiting the ability of increasing intra-abdominal pressure. The paraplegic has lost neural control of his or her abdominal musculature and therefore is unable to increase intra-abdominal pressure. The paraplegic patient usually has few problems with retained secretion as long as the cough is not needed. When stressed by even a mild cold, he may have severe retained secretions because of his or her inability to cough. There it is. Completion of chapter 8. Ding, ding, ding. We did it again. Shaking up the world, reading books live from the light here on YouTube. Thank you so much for reading chapter 8 with us. Bronchial hygiene therapy is complete. Retained secretions. That part of chapter 8 of bronchial hygiene. Clinical application of respiratory care. Chapter 8 complete. When we reconvene, we will be back with chapter 9. Thank you so much for being here. Highest heart, love, and honor. My family and friends, I love you so much. Thank you for reading books. Highest heart, love. I want you to have a wonderful Thursday. Shaking it up in the world. Reading books and learning from masters on this peaceful place on YouTube. Peace, Corey Oldham. Highest heart, love. Thank you. You said he'll sub. Thank you so much. We're going to get to 500 subs. Reading books. Just giving the people what they want. We had a beautiful, beautiful meditation yesterday, as well as the grocery giveaway. Grocery giveaway here in South LA Cafe 293. We give it out to the whole entire community. Wonderful groceries to help them out through their weeks. And it feeds a family of five, for a whole week. So they had some beautiful bags yesterday. Thank you so much, V. Highest Heart Love. Thank you, Peace, Australia. Much love. Thank you so much. We're moving. We're doing it. We just completed a whole chapter read. Thank you so much. Hey ya, hey ya, hey ya, hey ya, hey ya, hey ya, hey ya. Hey ya, hey ya, hey ya, hey ya, hey ya, hey ya, hey ya. Thank you so much. I love you. I love you. Love you. I love you. So let's have a drink of love water. Thank you so much. She said, thank you, beautiful brother. Oh, thank you, my love. Peace be and love to all my friends and family in Australia. Oh, peace, Marquise. Love to my friends and family all over. I love you. Have a drink of live libation, love water for all of you. Thank you so much. Mm. Oh, that's so great. Thank you for reading with me. Oh, man. Thank you for breathing with me. Love you. I will see you soon. Thank you. Oh my goodness. Yes, V. It was my birthday. It was my solar return. Thank you so much. Highest heart love. Yes. Today now I'm what? 16,805. Mm, I honor you. I love you. Always will. Much honor and love. Thank you to all my babies. Love you. Love and peace to Kendrick Mosley. You are now a grandfather. India just had a baby. Highest heart love to the new angel that we have in the world, another light worker. Light workers, we are unifying, healing the people, learning by mastering ourselves. I love you. I want you to have a wonderful Thursday. We have another year healing session today. So that it's going to be amazing. Heal the people. I'll talk to you soon. Peace.